Hello and welcome to the Veterans and Parkinson's Mobility and Driving Safety Program. I'm Erin McGee, Senior Community Program Manager for the Parkinson's Foundation, Minnesota and Dakota chapter. I'm delighted to be here today with all of you from across the country. As you see, each dot is a location of a viewer. We are very excited to reach veterans with Parkinson's disease and their care partner and families. And from all of us at the Parkinson's Foundation, thank you for your service, and a special thank you to the care partners and caregivers. As a wife of a veteran, I appreciate all that you do to support your veteran. Our program today will consist of presentations from Parkinson's experts from the VA healthcare system, as well as hearing from a veteran living with Parkinson's and his care partner. We will include a Q&A session at the end. We are grateful for the community organizations that have coordinated watch parties in the Midwest, including Cedar Rapids Metro Parkinson's Association in Iowa, Meadowlark Hills Parkinson's Program in Manhattan, Kansas, Element Boxing and Fitness Gym in St. Paul, Minnesota, Parkinson's Group of the Ozarks in Springfield, Missouri, Norm Waite Senior YMCA in South Sioux City, Nebraska, and Cincinnati Music and Wellness Coalition in Ohio.
Not bad.
We would like to thank Genentech, a member of the Roche Group, for their generous grant to support our series of virtual programs for veterans living with Parkinson's. For those who are joining us for the first time, I would like to take a moment to share the mission and the work of the Parkinson's Foundation. We are the nation's largest community for people living with Parkinson's. Our mission is to make life better for people with Parkinson's by improving care for everyone, advancing research toward a cure, and empowering and educating our global community. We offer an extensive set of resources, which includes our website, parkinson.org, our free educational book series that you can download or order in a hard copy from the library. We have a variety of recorded podcasts and webinars, and our hospital safety kit called Aware and Care. We also offer a free national helpline, which is staffed by Parkinson's specialists ready to assist. To access our resources and support, please contact our helpline at 1-800-473-4636 or email helpline@parkinson.org. Part of the Foundation's commitment is to reach every person living with Parkinson's. A critical way we do that is through partnerships. And with more than 110,000 veterans living with Parkinson's, the Foundation has established a formal partnership with the Veterans Administration with the overarching goal to improve the quality of life for veterans living with Parkinson's disease and their care partners through greater access to education, resource, and support. We have created a webpage dedicated to veterans living with Parkinson's at parkinson.org/veterans. On this page is an FAQ guide that provides an overview of Parkinson's disease and VA resources, benefits, and eligibility and access to care information. We are honored to support all of you on your Parkinson's journey. We have 2 more veterans-focused webinars this year. Please save the dates for August 18th on managing cognitive changes and October 17th on mental health and empowerment. In addition to veterans webinars, we offer weekly webinars through PD Health at Home. Join us for Mindfulness Mondays, Wellness Wednesdays, and Fitness Fridays. These webinars are recorded and available to watch at your convenience. And with that, I'm pleased to introduce our first speaker, Dr. Ergun Uc. Dr. Uc is the director of the Consortium Center at the Iowa City VA Healthcare System and is also a professor of neurology and director of the Division of Movement Disorders with University of Iowa Hospitals and Clinics, a Parkinson's Foundation Center of Excellence. It is truly an honor to welcome Dr. Uc. And with that, we'll have him join us and begin his presentation by sharing his slides.
All right. Do you hear me?
I can hear you.
Great. All right. And I'm sharing my screen now.
Dr. Uc, I see your slides and see you, but I'm not hearing your voice.
Do you hear my voice now?
There we go. Perfect. Thank you.
Okay. So, well, I'm very glad to be part of this distinguished group of speakers from Minneapolis, VA. And so I would like to first put things into context. So we will talk about mobility today. What's mobility? Mobility is the quality or state of being mobile or movable. And how does it fit into our lives? So activities of daily living can be divided into two, basic and instrumental. So basic activities of daily living are those types of things you do to take care of yourself, like going to the bathroom, eating, drinking. And instrumental activities of daily living are those that are important for functioning in the society. For example, like taking care of finances. So if we put it into mobility context, walking is a basic ADL, whereas its equivalent in instrumental ADL is driving. And both of these functions depend on intact motor, visual, and cognitive system. Motor system meaning all the systems related to movement. So in a way, actually walking and driving share many features. So today I will primarily talk about driving in Parkinson's disease. And this is our VA hospital here. And I have been working here since 1991 as a resident fellow and a faculty. And I started Parkinson's and DBS and clinics here back in 2001. And in between 96 and 2001, I was in Little Rock and worked at John McLellan VA. And this is our university hospital. And we are also very fortunate to have on our university campus the National Advanced Driving Simulator with whose researchers I collaborate on driving. So my research is funded by VA, NIH, and DoD and various foundations. There is no conflict of interest. So why is driving important? It enables independence and community mobility for people, important for maintaining quality of life, supports a sense of identity and competence, perceived stigma of losing license, and worry for burden to loved ones. So all these aspects are part of driving. Now, I will show you how we respond to a driving hazard. So this driver is from my studies, and he is a control participant, meaning somebody without Parkinson's disease or a clear neurological disorder. And our drivers are always in car A. And when car A approaches the intersection, car B gets triggered and jumps right in front of car A. So here we see the reaction of our so he's driving at 41 miles per hour.
Dr. Uc, I'm sorry to interrupt. We're just getting some feedback that we're having difficulty hearing you. Could you possibly adjust your microphone? Or turn up the volume? That would be so helpful to our online audience.
Okay, so do you still get the feedback?
We don't hear any feedback. We're just hearing your voice is a little softer. So maybe speak louder or adjust the microphone would be so helpful.
Okay, I think I will try to speak louder.
Wonderful, thank you so much.
Okay, so so here in this video, we are seeing a car approaching an intersection and a car would be jumping right in front of him. And he's able to stop very easily and avoids a collision. So this experiment is done under foggy conditions to make it more difficult. So how did this driver react? So the reaction takes place in the brain and in the body in less than 1 second. The driver sees the threat, plans a response from his memory of the potential responses, executes the action, watches what's going on, and does further action as needed. And as a result, he's able to stop and swerve. So that's the normal reaction. So here, I will show a patient with Parkinson's disease from our experiments. So he is driving at 53 miles per hour. He's coming to the intersection. He's already kind of swerving, and he crashed into the incoming vehicle at 33 miles per hour. So his reaction was too little and too late. Why? So why is driving impaired in Parkinson's disease? So in Parkinson's disease, the main problem or the most known problem is lack of dopamine or decreased dopamine in a certain part of the brain. And that leads to slowness, stiffness, tremors, and gait and balance difficulties. However, that's not the only issue. This dopamine is lost here, but there are many other chemicals that are affected in Parkinson's disease. And these different chemicals, their absence causes cognitive impairment, dementia, depression, anxiety, vision problems, and autonomic problems such as blood pressure control, bowel control, and also sleep regulation problems with insomnia or too much sleepiness. So as a result, Parkinson patients suffer from various issues that can affect their driving, such as slow processing of information and slow reaction times, decreased attention and multitasking, decreased decision-making ability, and impaired contrast sensitivity, meaning impaired night vision, decreased visuospatial perception. They cannot judge the relationship of things to each other in the scenery, increased sleepiness, difficulty controlling impulses sometimes, and decreased insight to shortcomings. As a result, in our patient with Parkinson's disease, all these different abilities, all these different steps that take place within 1 second are impaired, and therefore it can result in crashes if these abnormalities are strong enough. So I will try to put things into context now. So sorry, this is kind of a complicated slide, but Parkinson's disease is mainly known for the motor problems like tremors, slowness, stiffness, walking problems. But even before they start, there is another period I will touch on later. So the motor problems over time lead to difficulty with walking, using a walker, a cane, and falling and not being able to move. And it takes quite a bit of time depending on the age of the patient and the general characteristics of the disease. And during this time, they, especially initially, they respond well to medication or surgeries like deep brain stimulation. But even before their movements slow down and tremors appear, they have a period called prodromal period, during which they have various bodily problems, such as constipation, loss of smell, stomach, bladder issues, and eventually with progression of the disease, they cannot hold the blood pressure up when they stand up, called orthostatic hypotension. And there are sleep problems. Some of them even start before the diagnosis and include things like acting out the dreams, and eventually insomnia and sleepiness become also issues. Patients also have problems with depression, anxiety, apathy, meaning loss of interest in things, and can develop hallucinations. And even at the onset of the disease, about 20% of patients may have cognitive impairment, and that figure reaches later higher percentages. And many patients, if they live long enough and they have long enough disease, they can develop dementia. So, and the driving problems fit right in the area just before the beginning of illness and towards the moderate stages. So, and after a while, unfortunately, patients lose their ability to drive. But there is a period of about 5 to 10 years, patients continue driving, and most of this period can be safe. And I will talk about what kind of driving problems occur in Parkinson's disease and what can we do to diagnose them and try to mitigate them. So this is the group of collaborators with whom I did the following research I'm going to present. And what we did was we had 100 patients with Parkinson's disease, actually many of them from the VA in Iowa City, some from the university. And we followed these patients for several years. At the beginning, we did their memory and thinking tests, vision tests, and then we also tested them in a driving simulator, also in a special vehicle which had various cameras and sensors attached to it. And we tested them at the beginning and 2 years later in these driving instruments. And we followed the Department of Transportation records in terms of their crashes and citations. And we followed up with the patients to see how long they continued driving. This was supported by NIH. And what we found was that, first of all our patients were currently driving, licensed, experienced drivers, and they didn't have any other significant condition. They were in their mid-60s. Their disease duration was about 6 years or so. So they were like mild to moderate cases. And all of them were ambulatory. They were not demented. They were living in the community independently. And we tested them while their medications were working. Even though all these people appeared quite normal, they drove themselves to the appointments and to the research. When we tested them in depth, in detail, we found mild to moderate problems in their vision, cognition, mood questionnaires, and movement tests. So even if people appear to be quite functional, when you test them in depth, you can find some abnormalities compared to their peers. And how do they affect driving in Parkinson's disease? So first of all, some characteristics of our group of patients, they were, when we gave them a questionnaire about their driving, they said that they were driving slower and fewer days. When we compared to our control subjects, they all were taking already some measures to avoid problems in their driving. They were avoiding rush hour and busy roads. They were avoiding bad weather and night. They were preferring to be driven rather than driving themselves, and didn't rate themselves as very good drivers compared to the controls. And some had already received suggestion to drive. And the more of these avoidance measures they were using, the worse was their Parkinson's disease. So our group of patients had relative insight into their problem. So now, in the simulator, we were able to test them both in normal daylight condition, and then with a turning off the switch, we could turn in the same scenery into low visibility condition. What we observed is that in normal daylight condition, Parkinson patients had more weaving compared to control. So they were also violating the lane more often. But when we introduced fog to the same driving segment, the controls still remained normal, within normal limits, but Parkinson drivers had much more worsening of their weaving and lane violations. So one thing you should know is that mild abnormalities in driving with Parkinson's disease can be very much more accentuated if there is additional stress. That could be driving at night, driving in bad weather, or doing other things while you are driving. So now we also tested these participants in real road, in real car, as I mentioned. It was a 20-mile route in and around Iowa City. And what we found is that Parkinson patients had more problems to follow routes that were taught to them. They had more difficulty to identify objects along the roadway. And when we asked them to do mental arithmetic while driving, they did much worse in terms of their drives and the task itself. And these tasks, as I said, would make their driving much worse compared to controls. Now, an important thing is when we looked what was predicting their poor performance, the most important features were cognition and vision. It wasn't their tremors. Tremors were actually the least predictive of driving problem. The most predictive was their decision-making and visual difficulties. So I will give specific examples later. Now, this gentleman is driving, sorry for the glare. So he's driving on a straight two-lane freeway, a four-lane freeway, you know, with two lanes on each side. And it's a 65 mile per hour speed limit. He's starting at 59 here. So initially he was driving straight. Then we asked him to add up numbers that were given over the loudspeaker and now watch his speed and how he will behave in the lane. So his speed from 60s, after he starts counting, it goes up and down. He starts violating the lane. And his speed has become erratic. You know, it drops to 40s. It keeps violating the lane. So again, if you introduce an additional stress in addition to normal driving, driving deteriorates much more in Parkinson's disease compared to their peers. And this was predicted by the set shifting ability, you know, by decision-making ability. Now, when we compared our 100 patients to our 150 controls, what we found was that the Parkinson patients did a lot more driving errors compared to controls. That was at baseline. And these errors actually diminished if they were familiar with the roads. So if they were from Iowa City area, they did better in the test. Interestingly, 25% of our drivers with Parkinson's did as good as controls, so they were within normal limits. So basically, not everybody with Parkinson's disease makes more errors. And what were the most important predictors of road errors? It was their visual acuity and also processing of visual information. If they were slow in processing the visual information, they did a lot more errors. And these are the things we can test. So, and the most important errors, the most frequent errors were lane observance errors. They violated the lane, but all sorts of different errors were observed. Now, we invited these patients and controls to come back 2 years later and do the same drive. And of those, only 42% of Parkinson's came back and 69% of the controls came back 2 years later. And when we compared the baseline of the Parkinson and controls, we saw that the people who returned 2 years later at the beginning were doing as good as the controls. So the crop of the cream from the beginning came back 2 years later. Now let's see what happened 2 years later. So 2 years later, Parkinson patients had a lot more worsening of their error counts compared to controls. So they went into the abnormal range. So this basically tells us even 2 years is a real long time for driving safety in Parkinson's disease. So therefore, patients need to be checked periodically. In most cases, more frequent than every 2 years. And what we found was that if their baseline driving wasn't as good, if their baseline visual acuity wasn't as good, then they were more likely to have this deterioration 2 years later. And various cognitive tests, attention tests, also showed us who would deteriorate 2 years later. All right, so what happened to our patients in terms of crashes? What this figure shows is that compared to controls, Parkinson patients crashed about the same rate. So meaning Parkinson patients, when we follow them over 5-6 years, they didn't have more crashes compared to controls. Why? The reason is the people who would be crashing, who were at higher risk, they actually quit driving long before that happened. So Parkinson disease in our cohort did not necessarily lead to more crashes, but lead to more driving cessation. So, and in terms of taking driving tests and failing, when you look across many experiments, Parkinson patients seem to fail more often across many studies compared to controls. And what predicted failure in Parkinson's disease were difficulty at left turning in intersections and also weaving while they were driving at low speed and not being able to control the speed at high speed. So those types of problems were the reasons why the raters would fail them. So left turning at intersections is a particularly difficult maneuver to do. And what disease features suggested that these patients would be more likely to fail? Older age, worse motor scores, if their gait was already imbalanced, if they had poor vision, if they had worse attention and executive functions, they would fail more often. So how can we summarize driving in Parkinson's disease? So Parkinson patients do more safety errors than controls and fail the test more often, but a proportion of drivers with Parkinson's could be normal too, in terms of their driving safety. Multitasking makes driving in Parkinson's much worse compared to controls. And the biggest predictors of driving impairment were vision and cognition problems rather than the motor problems, such as tremors. And Parkinson patients declined much faster compared to our controls. And they were more likely to stop driving compared to controls. So how should we approach fitness to drive in Parkinson's disease or similar disorders? So basically, we really need to evaluate every patient case by case because everybody is different. And it should be a multidisciplinary evaluation, meaning just a neurologist or a family doctor is not enough to pass the judgment. It should be a group of experts in cognition, neuropsychology, ophthalmology, occupational therapy, physical therapy. So these people would evaluate all aspects of the patient and can together come to a consensus, and then their neurologists can give them the news, or whoever is involved directly in the care. Now, how does the process start? So if there is a concern by the patient or the family or a referring primary care provider, first, we evaluate the patient's cognition, mobility, and vision at bedside, when they come to the clinic. And if needed, I send my patients to neuropsychological testing and also sometimes for vision testing. So if unsure, if the tests are not very informative, but they show that the patient is safe enough to take a road test, I send them to DOT, to Department of Transportation, for a repeat road test. And I usually do it for most of my patients every year. I fill out their forms. However, if the neuropsychological and vision tests are clearly impaired, I recommend driving cessation, and most of my patients oblige. However, if there is more uncertainty, what I do is, and we are very fortunate at the VA because we have driving clinic. So I send my patients to the driving clinic in Des Moines, which is run by an occupational therapist. And the occupational therapist there does special cognitive and vision testing. And if he or she finds them good enough, safe enough to take behind the wheel, they also take them for the behind the wheel test. So there are also private companies, but insurance doesn't pay for the behind the wheel portion, but at the VA, this is not a problem. Now, in terms of reporting medically impaired drivers, so these rules are not uniform. So one needs to know what the rules are in your state or in your country. And in general, the principles recommended by the American Academy of Neurology is, they report optional reporting of individuals with medical conditions that may impact driving, especially if public safety is compromised. But there should be immunity for both reporting and not reporting when everything is done in good faith. Now, how can we mitigate? And my colleagues, Hillary and Derrick, will talk more about this. But you can either opt to improve the driving skills themselves, try to train them how to do certain maneuvers and so forth, like the therapy equivalent. Or you can try to train the underlying problem, improve the underlying problem, try to improve their vision, try to improve their cognition with various methods, if possible, and treat their cognitive and motor symptoms effectively. So probably there needs to be a combined approach. Now, I will talk very briefly about exercise. I know that Ms. Olson will talk in more detail. And so exercise is known that it not only improves physical function, but by improving brain health, it has the potential also to improve cognition. So I did a study with my collaborators about 10 years ago, which showed that aerobic walking improved Parkinson features and executive functions, such as decision making and so forth, that are important for driving. And also there were some good changes on the brain MRI. And this study actually got lots of attention, even was published in the lay press. But the study was not controlled and it was very small. It was another study that was funded by the VA. So I got another grant recently to study this subject further. So in this currently ongoing study, I am allocating patients either to aerobic exercise or health education, and then do their brain images, fitness testing, Parkinson testing, and even driving to see if aerobic exercise would improve movement, cognition, as well as driving, because driving depends on those things. So, and the results will be out in about 2.5 years. So if you live in Iowa City area, and if you're an active driver and meet various other eligibility criteria, we would welcome you to have you in the study. So how can you make driving safer in Parkinson's disease? Be aware of your limitations. However, one should also know that Parkinson's, by causing cognitive problems, can impair the insight and judgment. Sometimes patients may not realize that they have various deficits. Listen to your caregivers and healthcare providers, and undertake cognitive and vision and driving tests if necessary. Also use compensatory maneuvers, such as avoid driving at night in bad weather and in unfamiliar locations. Avoid busy intersections and unprotected left turns. So unprotected left turns are where you would be at most risk for crashes. And also avoid distractions. Don't call somebody, don't eat, don't even listen to heated radio shows, because anything that decreases your concentration from driving, that has bad effects on your driving. And that's true for everybody. And always keep your eyes on the road. With that, I would like to hand the podium to the virtual podium to Hillary Olson, physical therapist and program coordinator of Parkinson's disease and movement disorders program at Minneapolis VA healthcare system. Thank you.
Good morning. Are you able to see and hear me okay?
I can hear you.
Okay, can you see me okay?
Yes.
All right. Good morning, everyone. I am going to go ahead and does it look like I'm sharing my screen?
Not yet.
Okay, just a sec.
There we go.
Sorry, just moving back here. All right, are you seeing the notes slides?
Yes.
How about
There
that?
we go.
Okay.
Thanks, Hillary.
Thank you. Yep. Thank you for bearing with me. So good morning. Just wanted to start and say thank you to Dr. Uc for setting the stage for the rest of our talk this morning. I am very delighted to join all of you from the Minneapolis VA. As Dr. Uc mentioned, I've been a physical therapist with the Minneapolis VA for the past 16 years, working in all different realms of neurological rehabilitation. I've been really fortunate to work more specifically with the Parkinson's population over the past 5 or 6 years. And then for about the past 1.5 years, I've been also working administratively to really develop our Parkinson's disease and movement disorders program in Minneapolis. So just to start, Derrick and myself don't have any financial or other disclosures. I will just mention that when we're presenting a little bit later on some of our equipment and assistive devices and things of that nature, that there may be some brand names that we talk about, but there's not anything specifically that we're endorsing. It just might be something that we're issuing or that the VA is able to provide for you. So just keeping that in mind. So first, just kind of talking a little bit, Dr. Uc mentioned this a little bit earlier, but kind of those hallmark symptoms of Parkinson's disease and kind of how those can really affect mobility and looking at those through a physical therapist lens. So Dr. Uc was talking about the loss of dopamine. So this really happens because in Parkinson's disease, we're losing those neurons that carry or have dopamine. And really, by the time you get your Parkinson's diagnosis, even when it's early on, typically we've already seen about 60 to 70% loss of those neurons in the brain. And so that kind of manifests with all of these different types of symptoms. So we'll go into these in a little bit more detail and to kind of talk a little bit about why these matter. So in Parkinson's disease, we often find people with stooped posture. So if you can actually try this, I find it's pretty helpful just for reiterating and kind of as an exercise. So this is the only time your therapist will let you slouch during the talk today, but go ahead and just kind of go into that sort of stooped posture. So kind of rounded trunk, kind of forward shoulders, and then try to turn your trunk a little bit from side to side. And just kind of notice what you kind of feel as you do that. And then maybe try reaching with your arm out to the side or up overhead. And I just want you to pay attention to how much you're able to move when you're in this slouched or stooped posture. And then after you do that, I invite you to sit up as straight as you can. So your biggest, tallest posture. And then I want you to try turning your head or turning your body from side to side, like you're going to look behind you. And then try reaching up or out to the side again. And so what did you notice? So I know you're not unmuted, so it's hard to give out some responses, but hopefully what you appreciated was that when you sat up taller and with a better posture, you were able to actually move your extremities more and turn your trunk more. So that matters when we're talking about being independent with taking care of ourselves, doing things during the day, even just walking and moving from point A to point B. The other thing that it affects is if you're in that more stooped posture, we have a tendency to look down towards the floor. So that can really affect us socially as well if we're not making eye contact as much with our friends or our family, and just can also impact vision as well, just being able to see what you can see in your daily life. Another characteristic of Parkinson's disease is those slow and small movements. And this can really be impactful on when we're talking about time-sensitive needs like getting to the bathroom, especially when there's some urgency, potentially like overnight. It also can make being slow or having small movements can affect how productive our movements are. So when we're reaching and having the ability to generate force to put on a shirt or a sock, things like that, those can also make those tasks seem harder and more effortful. We also know that postural instability or trouble with balance can also be something that affects people with Parkinson's disease. And if we have either a smaller movement or a less effective movement to be able to try to catch ourselves, or we're just reacting slower, that could result in a fall. And if we're more fearful of falling, or we have this kind of instability, we might be less likely then to participate in either household activities or community activities. And then rigidity and stiffness, as I mentioned before, just in regards to some of the stooped posture, we can also see this relating to some pain and some decreased range of motion. And then finally, tremor can also impact our self-cares and our daily routine, and also can impact our balance if we're noticing them in our lower body or our legs. One thing I also wanted to bring up, we see this a lot in physical therapy and occupational therapy as well, but sometimes people have trouble with what we call low blood pressure or changes in blood pressure relating to changes in position. So the big fancy term we call it is orthostatic hypotension. So potentially that just means if you and I are sitting here listening to this talk for a while, and then I got to go get up to get a drink of water, I might get up pretty quickly and I might have a sudden drop or a quick drop in my blood pressure. And that just that's actually common in Parkinson's disease because of some dysregulation in our autonomic nervous system. So this can also make us a little bit more fearful of getting up and moving around. So we want to make sure that we have good strategies in place that can help with this. So these are a few strategies if you do tend to have low blood pressure and Parkinson's disease, a few things that you can do. So if you're going to get up to go to the bathroom or get a drink of water, one of the biggest things that I like to have people do is just move your legs around for a little bit before you do that. So you can, kind of march in place, you can point and flex your feet, you can squeeze your legs together, do 5 to 10 repetitions of each of those before you get up. You can also drink some cold water, especially in the morning, or if you know you're going to be standing for a long period of time. Make sure that you're taking time to make your transition. So all of these things will ultimately help with that lightheadedness or sometimes some dizziness that can contribute to instability and potentially falls risk. There's also a really great resource from Parkinson's Foundation that we'll also include later on with this handout in regards to these strategies that you can get from Parkinson's Foundation. So when we're talking about managing falls risk in order to be able to maintain our independence, so really we want all of you to be able to move for as long as you can with as quality of movement as you can. We want you to stay active. So if we look anywhere in this circle, in the top left side there, we know, as I mentioned, that our movements are less effective with Parkinson's disease. So they're smaller and they're slower. And then we potentially aren't moving around as well. So maybe we have an increased fear of falling. Well, that leads to us doing less for ourselves, or you're doing less for yourself and potentially relying on others or your care partners more. And then that leads to a loss of independence with those daily cares, taking care of yourself, getting dressed, moving around, transferring, and then it just kind of feeds into itself. So this is kind of the, if you don't use it, you lose it phenomenon. Another good quote that I like to use frequently is a body in motion stays in motion. So thinking about really trying to have some regular movement on a daily basis. So in regards to managing falls risk, what is the number one thing that you all can do is exercise. So we knew that was coming, right? You figured the physical therapist would talk to you about exercise. So there's lots and lots of evidence to support exercise being beneficial for people with Parkinson's disease. So as Dr. Uc mentioned in some of his research efforts as well, there's lots of emerging literature, and has been for many years now, that people with Parkinson's disease really should exercise. So we're going to talk a little bit about kind of the parameters for exercise in Parkinson's disease and what that might look like for you. So along the journey of Parkinson's disease, really thinking about revisiting individual goals. So kind of what matters to you, what is really important to you as you're living your life. I think that's something that your therapist can really work with on, and really everybody in your care team can help you with this. So it's really good that care partners and veterans with Parkinson's disease really are advocating for what it is that you'd like to keep doing and what are the most important things for you. So on the left-hand side of this chart, you can see we kind of have a process in regards to our level of function and kind of where we see kind of therapy and rehab. So prehab or prehabilitation is kind of this before there's really a whole lot of things that are wrong or that are really difficult for you. We want to get you into a regular exercise routine. So I think I mentioned this earlier, but we're, even at diagnosis of Parkinson's disease, we see there's already about 60 to 70% of neurons that are carrying that dopamine that are already lost. So even early, and the other factor of that is that even early on in the Parkinson's disease diagnosis, slowness and decreased amplitude of movement. So people aren't moving as big, they're not moving as fast as they previously were. And also there tends to be already in this early stage, there tends to be misperceptions of time and distance already when there's not a whole lot of other motor symptoms. So this is where we really want to help to establish that lifelong exercise habit. And then in the middle here, we see rehabilitation, and this is really focused around a specific goal. So maybe the individual with Parkinson's disease has trouble with shuffling while walking, or maybe they have trouble with turning, or maybe they're having a hard time getting up and down from the floor. So that's something that's really related around a goal. You're kind of doing a focused bout of therapy to work on that in order to improve and maintain mobility and independence, and also be less dependent on your care partners. At this time, we might also look at adapting leisure interests or other things that potentially you're interested in doing. And then as the disease progresses into moderate and advanced stages, we're looking at really being supportive for individuals with Parkinson's disease and their loved ones. We're looking at establishing potentially new norms, making some modifications, still allowing you to be as independent as you're able to be while decreasing how much support is coming from your care partners or your family members. And then also just considering to think about maybe making some adaptations at that time to things that you still enjoy doing. A great thing about the VA is that there are lots of programming options for adaptive leisure interests and other things. So that's something that is a great way to help you stay active. So Dr. Uc just reiterated this already, but of course, exercise is continuing to be studied in the Parkinson's population. Really, it promotes brain health because when you're exercising, you get blood flow both to the working muscles, but also to the brain. So that is how we're able to get some positive cognitive changes as well. It may help to slow the disease process, as we mentioned. Higher intensity exercise is more beneficial than moderate or low intensity exercise in people with Parkinson's disease. And then really encouraging you to work with your physical therapist to determine a Parkinson's specific exercise program for you that's based on your current activity and fitness level. So I think really early on in the process, we try to do a lot of what we would call motivational interviewing, really finding out what matters to you, what type of exercise or activities you enjoy. And the reason for that is that actually helps you stay with it longer. So if you're not a runner and I told you to run every day, you probably wouldn't like me very much, right? So thinking about finding something that you really enjoy to be able to promote you to stick with it from day to day. And then also setting realistic goals. So if you're someone who is relatively inactive and you maybe do more sitting throughout the day, which is completely, that's okay. But if we're looking to get you to start moving and you're interested in moving more, we're going to start with goals that are attainable. So not necessarily starting with 30 minutes of continuous exercise, but maybe just starting with activity breaks, taking breaks from sitting, moving your body around, and then gradually progressing, which is why it's good to work with a therapist to get you into some exercise. So data from Parkinson's Foundation Outcomes Project is a very large clinical study on Parkinson's disease. And this also supports that people that do 2.5 hours of exercise every week which is about 30 minutes a day, have a better quality of life. There was also a recent study that came out actually just in 2021 in December that shows that aerobic exercise, so that's that continuous whole body exercise, can really help to stabilize disease progression and also enhance cognitive performance in people with Parkinson's disease. So exercise is medicine. I like to instruct my veterans and the people that I'm working with Parkinson's disease to really think about exercise as much as you would think about taking your carbidopa-levodopa. So trying to get some regular exercise in every day. There's several different parameters of exercise that are important to keep in mind for people with Parkinson's disease. So the first thing I have listed here is external cues. And that is related to using something to potentially help you move bigger. So that could be like having someone give you a verbal cue what to do, maybe even just modeling. So do what I do if you're watching a video, or having an instructor lead a class. Using things that have like a specifically paced or cadence, like a metronome or music, a favorite song that you like can also help. And this has to do with people with Parkinson's being less likely to be able to change or grade their movement based on what they're doing. And then, as I mentioned previously too, we really want to encourage large or bigger amplitude movements during exercise, because otherwise people with Parkinson's will self-select kind of a smaller amplitude of movement. The intensity, as I mentioned, really matters. So people that did higher intensity versus moderate to lower intensity had more effects or more beneficial effects on their motor and non-motor symptoms. This is also a great tool, the Parkinson's exercise recommendations through Parkinson's Foundation. This is also available online, and we will include it with our resource list as well. What I do like to tell folks is that keeping in mind that even though it's listing out, I think if we look at this, it always looks like there's so many things to do. But there are ways that you can, say, participate in a Parkinson's specific exercise class, where you can get a variety of these categories kind of tackled all in one hour or half an hour session. So how we can promote exercise, and this is really working with your care partners and people that are in your supportive circle to help you with this exercise regimen and keep you on board. We find that scheduling it into the daily routine really works out best. I like to have people schedule it when they feel the best. Typically for a lot of folks, that's going to be like later morning. So after you've had a chance to kind of wake up, maybe move your body a little bit, take your medication, eat something. So maybe around 10 o'clock or so. If you tend to be more of an afternoon person, maybe you schedule it later into your day, but really scheduling it with your loved one if you need some reminders as well. Starting small, making realistic goals, as I talked about, using some form of external or outside cueing. And then really thinking about, if you're going to start an exercise program, thinking about focusing on that continuous whole body movement first, and something that's more task specific. So working on getting up from the chair, so sitting to standing, or something that's really going to have good carryover into your daily routine. And then also think about considering what works for you and your loved one. So really kind of integrating it into your schedule. And then really be kind to yourself and meet yourself where you are physically, mentally, and cognitively. Exercise doesn't have to be a chore. It can be fun, it can be engaging, and it can be done from a variety of different positions like sitting or standing. And this just kind of reiterates the same principles that I mentioned. And then thinking about how the role of physical therapy is important for people with Parkinson's disease. I think one thing that I would recommend is really establishing yourself with a rehab team. And we'll talk about that in a little bit, but thinking about having your therapist kind of follow you as the disease progresses. And this is going to look different for everyone because we all kind of come from different settings and different VA hospitals, and some of you might be seeking or having some of your care in the private sector, but just thinking about that we want someone who can kind of monitor us throughout the disease course. This ideally would look like a therapist that's familiar with you, that maybe sees you every 3 to 6 months for sort of what we refer to as an interval follow-up, kind of monitor how things are going so we can kind of be more proactive instead of reactive. But then if there is something that comes up, that we're able to then address that with a bout of therapy or some other type of intervention. There's a few resources that I'd just like to point out to you that again will be sent out following the presentation through the Minneapolis VA. Although this is specific to Minneapolis, there's lots of good resources on there that might just be good for kind of an educational standpoint, as well as the Parkinson's website through the VA is another good resource as well for specific resources in your area related to VA. The other thing I encourage folks to do, depending on who you're seeing from a neurology perspective, you know, it is okay and it is good to advocate to see a movement disorders specialist. That is the title for somebody a neurologist that specializes in movement disorders like Parkinson's disease. And then from there, you can request a referral to see someone in rehab or see some therapies. So as I mentioned, therapies kind of come in all different realms. We have physical, occupational, and speech therapy. You can kind of see the different things that they focus on across the board. And as I mentioned earlier, we're really here to maximize your quality of life and function, no matter where you're at in the disease stage. So there are many things that we have available to be able to provide to you to help you live your best life. And then another thing, just kind of thinking about, so we talked a little bit about mobility, we talked a little bit about exercise and falls risk and how that can be sort of that thing that you're targeting to really help you. And then sometimes we might need an assistive device for walking or for balance. And there are really a wide variety of things available. I do have a couple of things that I can show you today. So one of the things that you may or may not have heard of is there is a Parkinson's specific walker called the U-step walker. As you can see on the slide here, there on the left-hand side is the traditional handles. On the right-hand side, this is actually a newer model that has platforms. The reason why this walker is a little bit different than, say, a standard four-wheeled walker or a two-wheeled push walker is because it has a reverse brake mechanism. So I'll just go ahead and grab this. So what can happen sometimes in people with Parkinson's disease, I'm just going to kind of tilt this down so you can see. So if the brake is on right away. So as I move this, the brake is actually on. So in order to take the brake off, I have to pull up on the handle here. There's also an optional laser light that you can use as a visual cue to help step over. So that would be in the event of if you had a freezing episode or it was hard for you to get going. We talked about using those external cues. So that laser is a form of an external cue that you can use to kind of break through that freezing episode. The other reason why the U-step walker is nice is because sometimes the rollators or the four-wheel walkers can get a little bit fast. So sometimes people with Parkinson's have trouble with forward momentum or propulsion. So that can kind of get away from them a little bit more. So this one is a nicer option for that as well. There is also an option for a transport wheelchair that is a four-wheeled walker and a transport wheelchair combination. So this is just one option. So if you're needing something for longer distances. I'm just going to adjust my camera here. If you're needing something for longer distances, but you want to keep your mobility up, you might choose to use this. You can walk behind it like a regular four-wheeled walker. But then if you get tired or you start having trouble, or maybe you're having an off period, this has an option to be able to flip the leg rests down. And then instead of sitting or instead of standing and pushing it, you can actually go ahead and have a seat and then have a loved one or a care provider push you with it. So that's a transport walker and rollator, transport wheelchair and rollator combination. And any of these things can be utilized or evaluated with your therapist. And really, I always tell people it's best to try these things out. There's really no number one or best assistive device. It's really person specific. So it's good to work with your therapist on what's going to really work for you and help you be the safest that you can be while keeping your mobility up. So I also always tell folks that any of these assisted devices or durable medical equipment, Derrick's going to be talking about in a little bit as well, can be obtained through your local VA. Typically, you do need to have an evaluation before a therapist will order this type of equipment for you to make sure that it's appropriate and that you're safe using it. And like I said, proper training, and then just making sure that you can trial it and that it works for you. So with that, I'm going to hand it over to Derrick Kent. Derrick is an occupational therapist that I have the pleasure to work with every day at the Minneapolis VA. So thank you.
All righty, can you hear me?
Yes.
How about see me?
Yes, we can.
Okay, I see myself now. So as Hillary was mentioning, I work with her in our Parkinson's disease and other movement-related disorders program. I've been here now for 1 year doing that, but like she was saying before, roughly around 5 or 6 years with Parkinson's disease, but now solely in the Parkinson's disease realm right now. But because I encounter plenty of people that have either limited or no experience with occupational therapy, I'd figure I'd give you a brief overview of what it is and what we do. Occupational therapy helps people across the lifespan live life to the fullest by addressing the things they want and need to do through the therapeutic use of daily activities, or what we refer to as occupations. I oftentimes jokingly ask people when they hear the word occupation, what do you think of? Most people say job. And it's our job to holistically address your most important job, which are those things that it takes to live your life. So those daily activities, ADLs and IADLs that Dr. Uc and both Hillary kind of mentioned earlier, are things that we tend to focus on. Hillary, there you go. Here's a pretty comprehensive list of the things that we do target, but what I'm going to be focusing on today is home safety and fall prevention, driving and community mobility assessment, self-care routines, and functional cognition. Next slide. Not just specific to Parkinson's disease, but I think it's important to know that occupational therapists are specialists in promoting health and well-being, enhancing participation in performance and safety, modifying an occupation or a task, the approach to that task, or even the environment that that task is occurring in to better support your engagement. And then lastly, we can provide tools and other strategies to help to maximize your outcomes for participation, performance, and daily activities. Over the next few slides, I'm going to be discussing most of our basic ADLs, and we'll provide some strategies that are easy to implement that you guys can hopefully do right off the bat. In terms of stressing, I oftentimes encourage people to be sure that they allocate a dedicated amount of time. As Hillary had mentioned before, I use the phrase all the time, use it or lose it. If you're not participating in some of these tasks and skills and activities, it's going to be a little bit quicker of a progression in terms of which you may be losing some of these skills. So I always encourage participation in anything that you do. So this is not just specific to dressing, but any of your ADLs. Be sure that you're not rushing yourself. Allow yourself enough time to really participate. I think it's also helpful to navigate the steps of dressing in the same order, keeping a familiar routine, and generally keeping the steps as simple as you can. As Hillary had mentioned, it's important to utilize big intent or movements in any activity that we're doing. So instead of, trying to just kind of slowly reach back and put your arm into a jacket, it's really intentful, big movements to make sure that those things are moving along to kind of help to overcome that bradykinesia and hypokinesia. If you are needing some cueing, I encourage people to keep that simple, direct, and generally only when needed. I also encourage setting expectations, the expectation that you are going to participate in this activity each and every day. So things like, you try it 3 times and then I'll help, or how about you go ahead and try this for 5 minutes and then I can go ahead and try and help you. Recognizing that trial and error is okay, and knowing that each strategy that we use is not going to work for everyone, and it might not even work for day to day for the same person. As we know, we have ebbs and flows in our day-to-day performance. So recognizing because it didn't work one day doesn't necessarily mean that it won't work the next. So be sure to keep trying. And with all activities and all of our participation, I want you to make sure that we keep safety priority. If you are running the risk of an injury, be sure that you're modifying how it is that you're approaching it, or start to ask for help, or even bring those to our attention so we can come with some recommendations that can help to decrease those safety risks, because we want to avoid injury at all costs. Or we might look to modify your approach or the clothing, or even just adding some tools to the dressing routine. That includes things like dressing the most involved side first and undressing the stronger side first. Doing so in a seated position, and not just seated at the edge of the bed, but also seated with a supportive seat back, so that when you are perhaps pulling your pants up, you aren't just falling back in bed. When people are having not only motor planning, but difficulties with fatigue and also strength, if you're not supported by that back, it can be a little bit more challenging and frustrating as well. Thinking about short socks versus long socks. Short socks are generally a little bit easier. Mittens versus gloves. I also encourage people to utilize a breathing sequence that I have to help them to extend their reach down to the floor to put on socks. For whatever reason, people will oftentimes take a deep breath in and hold that, and now you're working against a large amount of air in your lungs and a very rigid diaphragm. So I'll encourage people to actually take a deep breath in, and as they're going down, go ahead and breathe it out. Now the position of your diaphragm is not only changed, but when you're breathing down there, it's not necessarily impeding that reach. So you'll find yourself getting an extra 1 to 2 inches for those that are not quite able to reach those toes any longer. And then lastly, loose fitting, lightweight clothing with synthetic lining are generally a little easier to get on. That isn't always possible here in our winter months to have lightweight clothing, but for sure looking for those synthetic linings, those things with less of that friction. So instead of using a flannel lining, having something that's a little bit more of that silky, slippery stuff that slips over not only skin, but also other clothing a little bit easier, are generally helpful. Here's some of the various regularly recommended pieces of equipment for dressing. We do have up on the top left the wing pants dressing aid. This is a dressing aid that helps to provide an opportunity to kind of open up the waistband of your pants or whatever lower extremity garment you might be putting on, and presenting those leg hole openings a little bit easier. We also can provide magnetic button adapters for those of us who are having some challenges in buttoning. There's also in the lower right-hand corner, as you see there, the button helper, which can help with that dexterity component of buttoning. Some as you see on the lower left-hand corner, those are some zipper pulls. So it's got a little clip along with a ring to help with that zipper pulling action. On the top right, we do have the elastic shoelaces with locking mechanism, reachers, as well as I think most people are familiar with a shoehorn. That's a long-handled shoehorn. But what I like even more so is the one just below it, which is the foot funnel. You can see the foot inserting into a essentially a rigid U that holds the heel up and allows you to slide in very, very easily. Then the one that you're seeing, the laser pointer there, that is also a sock aid to help out with the putting on a sock. Next slide. Here's some things that you can do for grooming, bathing, and/or hygiene. As I mentioned before, a lot of these strategies can be pretty universal, used in any of your ADLs. Seated is going to be important, but I do encourage people to keep doing things the same way as they always have, so long as they are safe in doing so. We start to look at modifying and adding tools if and when energy conservation starts to become an area that we need to address. Risk of falling is an issue, or just your independence in general. You're losing a skill, and we need to add those things to allow you to continue to participate. So if you don't need to, you go ahead and stand. If you feel safe in the shower, go ahead and stand, because that's using, as we said, those skills and strength that you need in order to continue on with and that transitions or translates to other activities as well. Stabilizing, we can provide grab bars, and we'll go over that a little bit more here in the future, or in future slides. But holding onto a grab bar as you're shampooing your hair is going to be a recommendation for when you are bathing. Or stabilizing your elbow on a table. Perhaps you're doing this in seating, and now you're stabilizing your elbow on a table. So now tremor can no longer emanate from the shoulder as much. So it might help to stabilize, and it's also using less strength and energy to do so, because now you can just kind of deliver your toothbrush or shaving a little bit easier with less effort. I also encourage people to look at, instead of using your traditional towel, which are generally pretty bulky and provide a lot of friction as you're trying to dry off, chamois towels are available, which are very lightweight, ultra wicking, less friction towels that may allow the veteran or individual with Parkinson's to participate in that a little bit more. If not used for simply hair drying, I've also encouraged people to try and mount hair dryers. I've seen a couple devices available. I haven't yet recommended one. People have usually been able to figure out how to do it on their own, but mounting a hair dryer to help with drying the hair or even the body as you sit. Transitioning to an electric toothbrush and or shaver. I encourage that, because tremor can be a pretty big issue that does run the risk, especially when shaving. If you're having a tremor, can be a little bit challenging, but they also help with that energy conservation as well, because you can allow the device itself to do the work for you. Same thing with toothbrushing. I've actually had people, hurt their gums a little bit because of the tremor. So allowing that toothbrush and just kind of holding it there as easily as you can be useful. With any of these tasks, I encourage people to organize their often used items in easy to access places. One of the easiest things to do is to grab a bin and have all of your grooming items into that bin and place it towards the front of the cupboard or drawer that you're going to be using. Very simple strategy to use. As I had mentioned before, if seated, and we can provide shower chairs, some people say that they don't need them currently, but then I would encourage them to maybe use that outside of the shower itself. Putting a towel on the back of that shower chair, and then on the floor, can help with drying the back and also your feet when you are done. Non-slip mats are also very important, because as we know, there can be sensation changes in the feet, and we want to make sure that those are as steady as they can be. With any of these tasks, pacing is also helpful. So instead of maybe showering showering and dressing all in the morning, maybe a shower at night, and then leave the dressing for the morning, can help to conserve some of that energy. And you'll see that I mentioned relaxation in multiple of these slides here, because relaxation can help to promote function in many ways, not only cognition, but also physically. It can help you to sleep, so you might have a little bit more energy. I've also noticed that it does help with mitigating tremor some, and a number of other positive effects from relaxation. Just quickly going to go over some simple strategies for cognition. Use of checklists, when you're going throughout your day, making sure, helping with memory, checking those off, so you're not having to remember those things as you go along, and also being able to reflect back upon the day. It's nice to be able to look at a checklist. This is what I did today. Use of a structured routine, so kind of doing the same thing every day on a scheduled basis. I do this, then this, then this. It helps with kind of keeping the flow of things moving, and helps with some of those difficulties that might involve initiating or thinking about what it is that I should do next. When it's kind of ingrained into you, it's easier to do. What I mean by everything needs a home, things like your phone, your keys, your wallet, they should be kept in the same place each and every time, so that you're not having to look for those things. It's just the rule of thumb is, once I've come into the door, there goes my keys, here's my wallet, and I know at the end of the night where I put my phone, so that they're just there and you know where to look for them. Use of reminders, and the Alexa device can be very useful, because you just have to ask her to do so and set a reminder for you if that's something you're looking to do. But I think the most important thing is just to keep things simple as they can be. Another thing is, people do tend to have less scheduled responsibility per se. I think it's also very important for people to be oriented to the day each and every day, so that you recognize today is June 21st of 2022, and just continually doing that to kind of keep yourself consistent and honest with that. As people progress a little bit more as well, I find that scrapbooking and photo albums can be very useful to kind of help to invoke some memories around some things and some conversation that might not otherwise be stimulated without that cue or that visual remembrance. I mean, they always say a photo's worth 1,000 words, or a picture's worth 1,000 words. It can really help to keep people engaged and involved in some of those conversations that they may otherwise find too difficult, because they just can't generate those thoughts themselves or independently. Labeling can be very important. Labeling not only cupboards, but where things are, that can be useful. And then again, relaxation. If you guys have any questions about some of those devices, really the only one that would be difficult to know is the tile. That's a device that we can provide here at the VA that helps to locate some of those things. As you can see on that specific device in the upper right hand corner, it's got the key ring hole. So that's essentially a device that you can use to place on your key, and if you happen to lose your keys, you can activate an alarm that goes off in order for you to be able to do that. They also have some that can be inserted into a wallet or a purse as well. Strategies and equipment for home safety. These are an example of many of the things that we can provide, although I have not yet, there's nothing with a tablet that I've specifically provided, but use of tablets can help with home safety. The call to you device that you see in the upper left-hand corner, that's essentially a two-way communication device that's kind of similar to what you may have seen in some of the older homes with, I think they call them like butler speakers, where you could call into a different room. This is kind of similar to that, where you can communicate back and forth with your loved one if they're in a specific area, can reach you in a different room. If you're having any worries about your loved one wandering, I encourage placing a bell on the door handle, so that you can at least be alerted when somebody was trying to leave the house. As you see in the upper right-hand corner there, that is a floor mat that can be placed at the edge of the bed. So when you put your feet down on the floor, and the weight of it initiates an alarm, so then you can be either awoken if you're no longer sleeping or sharing the same bed, or at least alerted that they're up and they may need some help in getting to the bathroom. A simple stop sign on the door can help. Putting that up on your front door so that stop, or at least it gets you to stop and think about, what am I doing? Am I just actually walking out this door for a specific reason, or should I not be going out there? Helps you to realize those things. There are a few watches out there that do have some fall detection services, none of which that the VA that I've been able to find provides, but there's a couple that you can get from your local AT&T, Sprint, whatever shop that I think for like $4 a month. It's a real simple device that can call and also detect falls. I like the puck lights for those individuals that don't really want to have a night light on at all times. So those can be used. They're just a quick, simple tap of the light itself, and the light goes on and can provide some of that lighting that you need to be able to get out of bed and to your bathroom. We can provide things like, I'm sure many of you are familiar with the Life Alert. We have a number of similar devices to that are available through the VA. And of course, those are generally done through evaluation with occupational therapy. And then one last thing that I just wanted to touch on is, as you can see with that stairwell, I like encouraging people to add contrasting steps, especially as you can see, it's kind of difficult from looking at that picture when the next step begins and when does the previous one end. At least by having that contrasting tape on the top and the bottom, if not all the steps, can help to alert you to be aware. Here's the step and here's the last step. If there are any wandering concerns, installing door locks and alarms, as I mentioned before, as we know, cheap ones can be found at most hardware stores or online. Encouraging to installing them a little bit higher or lower, so they're kind of out of sight, and then painting them the same color can help to camouflage and not necessarily recognize that they're even there. Requesting a medical ID bracelet generally happens through your primary care provider. Keeping items associated with outdoors out of view, and then disabling your community mobility devices, bicycles, cars, lawnmowers, golf carts, tractors, and so on and so forth. So let's talk a little bit about the home evaluation process. Generally, a consult is submitted at the request of our primary care providers, and how this occurs. This can either occur in the home if the veteran lives within 40 miles of the VA, or which is preferred through a telehealth visit, and in which we're seeing each other via video. So you'll need some sort of kind of transportable laptop, tablet, phone, where you can kind of bring us around the house and show us how this is set up. We generally interview for around 30 minutes, talk about your goals and what barriers that you're experiencing, the general layout of the home, performance with ADLs and IADLs, and past trialing of various equipment. And what have you used before? We're going to consider things in regards to your cognition, your functional mobility, vision, mood, and behavioral considerations. And then the actual assessment occurs of the medically necessary areas. That includes your bedroom, your bathroom, the kitchen, and perhaps the laundry if you are living alone. And then we'll give you some recommendations. So things that we can provide, or things that you should consider in terms of maybe reorienting a room or rearranging to decrease clutter and make those areas a little bit more navigable. We consider not only now, but also the future. Why do we do this? As we know, falling becomes a bit of a concern as we age, but also this is compounded by Parkinson's disease. So here's a little demographic about how that occurs over the lifespan. Go ahead, next slide. Here are the things that we're going to look at. And I put a picture of a poorly demonstrated ramp, which involves the door swinging out to the ramp. As you see there, it's also very steep. It would not meet the ADA recommendations. But what are some things that we can include? Not only grab bars, as you see listed on both of those pictures, or we can look at installing a ramp, and this can be provided through the VA. The criteria to meet that is that you must be dependent on a wheel mobility device. This is not only a wheelchair, but it can include some of those devices that Hillary was just showing, the rollators, the four-wheeled walkers, the U-step walker. And to know that you're only approved for one ramp at your primary entrance is also important to recognize. This can be ordered with mesh flooring for outdoors, as you see there on the right. That allows snow and rain to fall through. But as we know, these can take up quite a bit of room. So some of those things need to be considered because we do need to follow the ADA standard of, for every inch of height or rise, we have 12 feet of length. So they can get quite high pretty quickly. Next slide. In terms of evaluating the interior stairwell, we can look to ask, and I think you can press that one more time to show the stair glide, Hillary. We can have the vendor come in and install an additional handrail because, as we know, one side can be impacted more than the other. And I will encourage people to continue to use the stairs because that is exercise, that is endurance, that is all those things that you need to be doing. And since one side can be impacted more than the other, we want to make sure that you have your strong side on regardless of going up or down. In order for a stair glide to be approved, as you see there, and that can be done through our prosthetics department, it must be accessing a medically necessary area. So for instance, your bedroom, your bathroom, your kitchen are all upstairs. Those would be medically necessary for you to get up there. But let's just say, I want to get one into the downstairs. You live in a Rambler, I want to get one downstairs. And that's really just an entertainment room. Well, those things can be done up on your main floor as well. Go ahead, next slide. Here are some showers and different devices that you can that we can recommend. Grab bars, as I'm sure you are all familiar with. There is the tub safety rail that you see down in the lower right hand corner, just clamps onto the tub itself. These can all be provided, as I said, through us. A handheld shower hose and wand so that you can kind of direct where the water is going, helps to limit your need to move around. Tub transfer bench that you see in the upper left hand corner. There's also a modified version where it's actually a sliding one, so it slides on a rail system. A pop-up shower, I have not had one of those or had any of those needed to be recommended. But for instance, if there wasn't a main floor shower, you're living on the main floor, and there was no access to any alternative, we might include, or we might be able to get one of those approved. For toileting, a commode chair or spill-proof urinal, I oftentimes encourage people to, or will provide those for people with frequent urination at night. It's going to alleviate the risk of falls when trying to get from your bed to your bathroom by having that commode chair and or this spill-proof urinal right there with you. Because in low light conditions, especially at night, I'm sure many of you have recognized you're a little less mobile in the early morning hours or overnight when you are just waking up. But there are a number of other devices as well. We'll keep moving because I am running short on time. We get a lot of requests for various things that people want covered, and these are some of the things that are not. Your traditional lift chairs, those recliners that will power lift you up and out, those are not medically necessary. Walk-in tubs, people often say, well, I need that to help to loosen my body up, and it's not something that we're going to approve because they're not necessarily all that safe. And I know that early on those things took a long while to drain and people were left very, very cold before they could get out of there. Home elevators, new pathways, new decks, security systems. I've had people ask for coming in and helping to remove some mold, getting new windows, and even a generator. So what can we do? There is the HISA grant, which is the Home Improvements and Structural Alteration Grant. This is done after, this can be done after deemed necessary by a home OT eval, and that can be done by request of the primary care provider to us, and recognizing that other alternatives have been used before as well. This can be used one time throughout the entire lifetime for specific home improvements if deemed appropriate. So let's say, you have a tub shower, but if you tried this tub bench, this tub transfer bench, okay, that didn't work because you don't have the correct space in there, then we might be able to look at using these funds. Recognizing that these funds might not cover the entire cost. It's not intended to. It's there to help to supplement these costs. So for somebody who's either not service connected or up to 49% service connected, you can be approved for up to $2,000 for some of these alterations. And somebody from in the 50 to 100% category is approved for up to $6,800. Recognizing that if you believe that you should be at a higher service connected percentage, I always encourage people to communicate or contact their county veteran service officer to help them navigate the system or to apply or reapply. The most common things include walk-in or roll-in showers, ADA toilets, widening doorways, or increasing the accessibility and square footage of a specific space. If you're looking at getting a new home, I encourage you to look for a place with no steps at the entrance. Main floor living, as I had said, so your bedroom, bathroom, kitchen, living room, and even laundry, if you can, is all there on the main floor. Larger square footage with widened hallways is going to help. Walk-in or even roll-in shower access. The zero threshold with more than 36 by 36 is always recommended. At least a 32-inch doorway. Higher toilets, so your standard ones run 14 to 15 inches, and it is recognizable. A 17 to 19 is much more comfortable and easier to get up from. Low friction flooring, such as luxury vinyl flank and hardwood or optimal carpeting, can be a little bit more friction and difficult to walk across. It also doesn't do too well with either a wheelchair or a rollator, especially those high profile ones. And then real quickly, just to kind of reiterate, occupational therapists here at our Minneapolis VA are typically kind of your go-tos for evaluating the driving and driving fitness. A generalist such as myself, when it comes to driving, can kind of deem somebody as a low risk or high risk. Those are the categories that are pretty cut and dry based on their physical, cognitive, and visual proponents. If we find that somebody's in kind of that gray area, we'll then refer on to our driving rehab specialist, which will then further evaluate and potentially bring them behind the wheel. I think it's important for us to recognize, or everyone to recognize, that it's not our job to take anything away. We actually cannot, say, cut up your driver's license or anything like that. It is our duty to provide you with recommendations to keep you on the road as safely, but also as long as you possibly can. Next slide, please. So these are the different things that we look at and how we assess trails A and B, visual tracking, as you see up on the top left hand, visual tracking and attention with Bell's cancellation on the right. Your visual acuity. There are very specific, as you see, that you get from the doctors to check your acuity for need for glasses. There are some very rigid, cut and dry levels for how much vision you need, and actually some speeds that would be recommended. If you're at 2040, I think is the bare minimum threshold for no restrictions. Once you get into the 2050 range for vision, then we're starting to recommend slower areas. I think it's 55 miles an hour or below. The one in the middle on the bottom there is kind of how how we test glare and how easily your eyes are able to change or accommodate to changing light patterns. As we know, light's coming by at nighttime. There's a quick and easy evaluation for that. And much like Dr. Uc was showing, we also look at the physical brake reaction time. We need somebody to be able to come in under 1 second, going from the gas pedal into completely that full transition of going onto the brake has to be below 1 second to meet that threshold. Next slide. So this is a list of kind of the things that we look at, and here are cutoffs. In the low risk category, you can take a look at those things all at your own leisure, but those are the cutoffs that go on with saying, okay, you don't even need a behind the wheel because everything looks pretty good because of X, Y, and Z. Versus the high risk, these things are not going to go so well. So we would then recommend cessation or retiring from driving, at which point we can help you find some resources and different things to help you get around town. That moderate risk is where we're going to refer on to our driving rehab specialists, which are also occupational therapists. Oh, and I think it's important to mention that was developed by Anne. Forgetting her name real quick. She's from Duluth. She helped to developed
Clark.
the drive. And Clark, thank you. You have my notes right there. And Clark, who's a driving rehab specialist who works at the Northland Driving School and created kind of this driving list calculator. And then in conjunction with some of my colleagues here, they came together and came up with all the things that we have here as well. Next slide. So how do you know? Scoring high in multiple of those areas, we're going to say no. If you're starting to have difficulties in your IADL tasks, such as medication management, finances, and various cooking tasks, that's generally a pretty good indication that you're not going to have the cognitive facets needed to do that. If family members or you are reporting getting lost in familiar areas, memory might not be good. Unknown scratches or dents, depth perception, not even recognizing or being aware that you may have bumped something. And then family not really feeling comfortable and wanting to drive with them is another one. Next slide. So cognition, obviously this is a big part of driving, but it's also a part of the process of Parkinson's disease, or maybe. Research shows that up to 20 to 50% of people with Parkinson's disease can expect to have some mild form of cognitive impairment. Early changes tend to be limited to 1 or 2 mental areas. Attention, those ones listed there. Next slide. So what do we as occupational therapists? Our gold standard is the cognitive performance test. This takes a look at functional cognition. It's a standardized test, takes about 60 minutes. It's not used to diagnose, but it can help to explain or predict capacity to function in various contexts and help to guide our intervention plans or provide caregiver education. Next slide. So what now? If you start to have these concerns, be sure that you're bringing that to the attention of your caregivers, your doctors. You can look to see a psychologist or neurologist or neuropsychologist for assessment. Occupational therapy can help you to find strategies for adapting and coping. Speech therapists helping with your language difficulties that you might be experiencing, or a physical therapist that can help to address your gait, balance, and other mobility related functions. Next slide. I think that's it.
Thank you so much, Derrick. That was a lot of information. And just a reminder, we are recording today's program, so we will definitely be sending that in the follow-up email. All right, next, I would love to introduce a veteran and his spouse to share a little bit about their journey with Parkinson's. And we'll also have Hillary joining us to get this conversation going. So we're going to invite Gino and Kathy to join us. And I know we had a little bit of technical difficulties, so we'll see if they're able to pop on with us right now. Hi, Gene and Kathy. Let's check your audio.
Good afternoon.
Wonderful. Thank you for joining us. All right, Hillary, are you ready to start conversation with Jean and Kelly?
I am.
Wonderful.
Hi, Jean and Kathy. How are you?
Good. How are you?
Good. You guys can hear me okay?
Yes. Yes.
All right, perfect. Just wanted to thank you both again for joining us for this virtual presentation today. The first thing I wanted to ask you is, I want to introduce you, Gino, and just let folks know that you are a Vietnam era veteran and who does receive his care at the Minneapolis VA. Gino, do you want to talk briefly about your journey with Parkinson's disease?
Yes, I would, but first, yes, I want to let you people know that I am a Vietnam vet. I was over in Vietnam for a year in 1966 and 1967. And I came home and didn't have any issues, but I realized later on that I'm having tremor issues. And one of the psychologists or psychiatrists at the Minneapolis VA is the one that noted I was having some tremors, and the rest is history.
So you started having trouble, you noticed tremor for a number of years first, correct? And then I think you had mentioned you were diagnosed maybe around 2018. Does that sound right?
Somewhere about in that era, yeah. That year or two, it kind of all goes together. I've been out there receiving some excellent care for a few more years than that.
Yes.
Hmm.
So do you want to talk, maybe talk to us a little bit about your care for Parkinson's through the VA?
It really took, I've seen a therapist for a few months, and then they came up with a program. It was a 7-week program in that we stayed right there at the VA in Minneapolis, and it covered our motion, our speech, just a whole lot of things it covered that I had no idea I was having issues with. I didn't know I was shuffling along. I didn't know I was not speaking with intent. And by golly, they taught me I was doing these things and gave me some things to work with and work on, and I continue to this day to use those. So it's been a heck of a trip, but a wonderful trip.
That's great. And so Gino's referring to, he did an intensive therapy program that was an inpatient program in Minneapolis, but some of you may have heard about LSVT Big and Loud, and many places offer it on the outpatient side as well. And then what about, how about, this can be for both of you, so Kathy and or Gino, but how do you guys navigate the challenges related to Parkinson's disease and together?
Okay. If I didn't have my wife here, I'd probably had fallen a number of times. She stops me when I get dizzy sometimes when I'm exerting myself, when I'm moving too quickly. And so she's grabbed me and held me up or put me up against the wall quickly so I'd stabilize. So what else have you done for me?
The caregivers are the first ones to see everything, probably long before you guys have at the VA and everything. So it's hard sometimes bringing it up because they can be real stubborn, but it's necessary. And if you have to grab them, if you have to just look them straight in the eye and everything, but the VA has worked miracles. He wouldn't be here without the VA. I encourage you to get involved in the therapy and anything that the VA recommends, because it saved his life. It's helped his attitude, his emotional health, everything. He really is. He was going downhill real fast and he got involved with the AA, and it's a completely different story. So
the VA.
What did I say?
AA.
Oh, VA, not AA.
You know what you meant.
Okay.
And then what about, Gino, do you want to talk a little bit about some of the ongoing therapy or the exercise classes or things that you've been involved with in the VA to kind of keep up with those initial skills that you used in that intensive program that you did several years ago?
Certainly. They have programs that are video chats, I call them, instead of Zooms, that weekly I go through a set of exercises. They happen to be with Hillary most often, that keep me mobile. If I wasn't doing those, I would have fallen right back into slow speech and slow movement and shuffling. But the program that I do with Hillary is awesome. It really keeps me going. And I also once a week do a loud crowd. I don't know what
Video group.
Yeah, with a group on through VV. They don't have to go to the VA to get it, and that has, I know, yeah, I know have improved with that, just being able to speak loudly with intent. And I do it most often, except unless I get really tired. So that program has helped me also. And I've gone through a couple, 3, 4 different teachers or instructors or therapists on that, and they're all equal. They all teach me how to live a better life, more healthy.
That's great, Gino. So just in kind of wrapping up, what are some of if you had to give advice to your fellow veterans with Parkinson's disease or to their loved ones or care partners, what would you guys like to tell them? Maybe a few things or just a brief thing from each of you.
I'd like to say that one thing that he's kind of stopped doing is do not compare yourselves with other veterans and their journeys, because you go into the VA and you'll see somebody that's had you never know how long they've had it, but they're moving better and everything. And he says, what am I doing wrong? Or, it's an individual journey, and attitude is everything. If you get up in the morning and feel sorry for yourself and don't do it, you're going to be able to tell. Keep busy. And the caregivers, if you got to put your foot down, then you got to do it. You're not real popular all the time, but I don't think we ever have been anyhow. So, yeah, just do what the VA tells you to do and do it happily, and you will notice a huge difference.
Thank you. How about you, Gino?
I'd say that even though I'm just doing a weekly programs for physical therapy and for the loud crowd, you have to do that stuff throughout your daily life. You can't just holler loud on Fridays. You got to speak with intent as much as
all the time.
All the time, yes. So it's something I've learned.
Mm-hmm.
Yes.
Can I say one more thing?
Yeah, go ahead, Kathy.
Caregivers and vets, it's okay to get angry because it's not your fault. This disease is very unfair, but you got to let it out too. If you keep stuffing that anger and saying, hey, I'll go to the VA and everything will be hunky-dory, let it out and talk to somebody, no matter who it is, because it's okay to be angry, but get it out of your system or that's going to kill you too. So.
And I'll also just add that depending on where you are and what resources your VA has, there are resources for family support as well. So, if Gino is able to get psychology support, but he's also able to get some couples support for him and Kathy. And then if Kathy wanted to, she could also get some family support too. So those are resources, depending on where you're located, can be available also virtually as well. So I just want to thank you both for joining, and we appreciate your feedback and your input and your active participation in your healthcare, and I think in general. And I think next up we have general question and answers. So if you guys wouldn't mind sticking around, that would be great.
Okay, thank you.
Thank you.
Yes.
Thank you, Hillary and
Welcome.
Gino and Kathy. I just
You're
take
welcome.
away all the positivity and all the things that you have to say about being an active role in your healthcare. So we'll also have Derrick and Dr. Uc come back, and we have some time for some Q&A from our live audience members. So Hillary, I'll get started with you. From a patient who has seen firsthand the importance of exercising and strengthening my core, can you speak to the importance of that and how people with Parkinson's can incorporate this?
So just in regards to exercise in general, kind of like I talked about, I think it's really important to get onto a daily routine. I think some people have more exercise experience than others. So that's why, you know, some of you all might be able to come up with an individual exercise routine pretty easily. And some people really maybe don't have as much exercise experience. And that's where I might invite you to work with your physical or occupational therapist to come up with a program that works for you. In regards to kind of core strength and mobility, some of the things that I mentioned earlier, just kind of moving your body, especially in regards to some of the trunk stiffness that happens. So exercises that incorporate some of those trunk movements and trunk strengthening can help just make our daily activities a little bit easier.
Thank you. And thanks, Gino, for the demonstration there as well. I liked that.
All kind of know
I don't
there's
even
still
know
one.
I do it. I just do it a lot.
That's great. Derrick, this is for you. You had mentioned cueing in your presentation. Can you clarify or give us some more explanation on what cueing can be?
Yeah, cueing can come in the form of verbal, physical, or tactile. Like I had said in the presentation, it's important to keep it simple, direct, and brief. So if you can, just limit the use of words and be very direct. So for instance, I need you to go get dressed. Maybe it's, why don't you go grab your clothes, you know, instead of the whole aspect of dressing in general, start with, can you go grab your clothes that you wanna wear for today? And then you could provide the next cue. Okay, go ahead and put on your shirt. Okay, go ahead and put on your pants. So instead of that whole thing, which may seem a little bit too unachievable, just starting with the first step and keeping that brief and simple, as I was saying before.
Okay, thank you.
Mm-hmm.
All right. This is for Hillary and Derrick. So Hillary, will start you first. Attendees are asking if there are any home appliances or equipment that make it easy for daily living, specifically helping you get off the floor if you fall.
Yes, so thank you for bringing that up. That is a great question. There are some specific, so I would say twofold. One is a little bit more of an active strategy. So working with your physical therapist on floor transfers, or we call it fall recovery training, which is kind of the souped up version of getting up and down from the floor. And then the other thing I would say is that we have some devices. For instance, there are some different devices that you can use, go through training with your therapist, as well as a vendor that provides the floor transfer assistance, keeping in mind that those types of devices would be used if you've fallen and you're not injured. So let's say that you fall, you're not injured, you have someone there that can assist you, but you maybe they're not able to 100% physically assist you and you can't get up on your own. There are some devices that VA can provide to assist with floor transfers.
Mm-hmm. And the other thing, instead of the devices themselves that Hillary was mentioning, I will oftentimes, as I mentioned in the presentation, the life alert pieces of equipment. We do have some other ones that can be taken anywhere. It's not just restricted to the 600 feet within the modem of the home. So if you were to have a fall in the community and maybe you weren't even sure where you were, it does utilize some of that GPS specific data to kind of figure out where it is. And then it's a two-way communication device where you connect with an operator, and then you indicate, can you call my wife or my neighbor John or whoever it might be, and have them come help me get up. You know, if you're, like Hillary was mentioning, if you don't feel injured, but you just can't get yourself up, having somebody come and help you can be useful.
Yeah, that's very cool. I did not know the GPS of doesn't have to just be in the home. It could be anywhere.
Yep.
That's great. Gino and Kathy, I see you nodding. Do you have any experience with any durable medical equipment? Oh, you're muted still. Hold on, Gino, you're muted. We can't hear you. There you go.
Can you hear me now? No, we
Yes.
don't have one, but boy, that sounds like it'd be a really good thing for people to have. That if you go out for a walk and fall over and nobody's watching, look out. That'd be a good deal.
Yeah, and I think it's important to recognize that there are some stipulations around that. There are some things that you should kind of demonstrate, but I find it pretty easy to pass through with the Parkinson's ailments. You know, because oftentimes one of the criteria is, well, having a cell phone can kind of be the same thing. But when you're thinking about Parkinson's, reaching your hand into your pocket is hard enough the way it is. But now if you're laying on the phone and trying to reach into your pocket, that's, you know, tenfold even more challenging. So they're generally pretty easy to get through on that. And the beauty is that it can be taken anywhere. It's not just confined to your own home.
Yep. I like it.
Thank you. Dr. Uc, in your presentation, you talked a whole variety on driving. Just wanted to clarify, does everyone with Parkinson's have mobility challenges and falls as the disease progresses? And then that relates to driving.
Well, essentially, yes. The short answer is yes, but it depends on where you are in your disease and also what kind of subtype you have. So some patients mainly present with tremor, resting tremor, and that can stay that way for a long time. And eventually slowness and stiffness and gait problems may add, but it may be many years later. So that's called tremor dominant Parkinson's. There is also what we call a kinetic rigid, meaning, you know, with little movement and lots of stiffness. So those patients typically don't have much tremor or no tremor at all. So you can have Parkinson's without tremor. And those patients tend to have gait and balance problems from very early on. And sometimes we consider alternative diagnosis, what we call Parkinson plus diseases. So, but essentially, almost everybody does, but the disease is so individual. Every patient follows a different course. For some patients, it can come 15, 20 years later. For some patients, it can come 3-4 years later. And also age is important as well. So if you get it younger, usually you maintain your response to medications and your mobility quite longer. Whereas if you get it older, you know, you may reach those milestones quicker. And also another important thing is the disease affects not just dopamine and other centers, and those other centers can affect balance that may not be responsive to medications.
All right, thank you for that. Hillary, we have a question for you. If a person's knees are feeling weak and they cannot tolerate getting on all fours or lifting weight above their knees, and they've had a fall and they cannot find a furniture or a way to prop themselves up, is there something you can do to help train that person to stand up on their own?
Yeah, so there's a couple ways that we can help people get up from the floor. First of all, I would say, like I encouraged before, making sure that you are aware that you're safe and uninjured before you try to start getting up. This might be something that you need practice for. I did also type this in the chat, but sometimes we will also train people. So if you're completely down on the floor, of course, I'm going to do a demonstration. So if you're completely down on the floor, on your stomach, and even if you can't get on your knees, you can kind of hover, take some core strength. We do it in exercise group. Walk your hands back towards your legs, and then walk your hands up your legs, and then come up. So, like I said, it takes some effort and some practice, but there are different ways to get up and down from the floor if you are wanting to try that and maybe don't have that equipment or it's something that you want to work on. It's also great functional strengthening as well.
And I think if you don't have that strength or you can't do so, I think bringing a chair over to the person themselves can also be useful so that they climb up that.
They were saying that they didn't have a chair though. See, that was.
I was doing something else as we mentioned before.
Yeah.
But then it ties into your home evaluation of like, where do you need to have props or.
Yes. I would always recommend having a chair, even for, having something nearby. So I would just say as a caveat, work with your therapist on different ways. We're pretty good at problem solving between PT and OT, so we can help you with those things.
That's great. All right, we're going to wrap up with one last question. And I'm going to address this to Kathy and Gino first, and then you others can chime in. But how do you handle some tough topics, as today is talking about mobility and driving? We've had a couple people comment they're concerned about their loved one with Parkinson's is losing some driving skills, awareness, reaction time. How can a caregiver approach this sensitive topic?
She can't. No, you can try and you're going to be forced to, but the doctor's presentation on the driving to begin with was just eye-opening and very, very hard to watch, actually, because that's one of the last things that these guys have that they don't want to give up. But I've mentioned a few things that I've noticed driving, but I think we're going to kind of try to rely on you guys at the VA to give your input a lot on the different areas that you can test or observe or whatever, because they're going to listen to you guys a whole lot more than they're going to listen to us.
And of course, I'm going to say I do have a few issues, but I think I drive safer than most of the other drivers out there. I'm a slow driver. I hit the speed limit and stay within a couple all the time. So, and try to watch for everything around me. So,
In the left lane with cars going 80 miles an hour drives me nuts.
I think the other thing that you can do, like Kathy mentioned, is you can blame your healthcare team too. Like Derrick said, X, Y, and Z. Dr. Uc said, Hillary said, you can do, so I think you can kind of use us as leverage. And then I would just say, have the conversation with your healthcare, your appropriate healthcare provider, your care partner, and you all together. Because really, we want what's best for you, the veteran with Parkinson's disease, and it's about us working together to make sure that we're meeting your needs and that you're safe.
And as I tried to kind of verbalize, is that it's not our duty to take anything away. We cannot say that you are no longer fit for driving and cut up a license. Those things do not happen. So recognizing that we're there again to keep you on the road as long as possible, but as safe as possible. So if you're unsure, we can provide you with the appropriate assessments and recommendations to make those determinations, and then recommendations to help you be safer, but might just kind of change the way in which you do drive. Some recommendations like Dr. Uc was saying, keeping it local, driving under 55 miles an hour, under 40 miles an hour, no longer driving at night, simple things like that, just to ensure based on what it is that you're demonstrating to us, this is what our recommendation would be.
Dr. Uc, do you have something to mention?
Yeah, sure. Well, first of all, this is certainly a very important topic. And as I mentioned, driving has so many components to it. So therefore, it has to be approached as a team, starting with your family, care partners, primary care providers, and your neurologists, physical therapist, occupational therapist, your eye doctor. So everybody has a role. And for some patients, the role of one aspect is more important than the other. And there are certainly parts of this equation which can be fixed easier than others, and the others that cannot be fixed. But if you work with a team like available at the Minneapolis VA or Iowa City VA, then people, I think your driving would be probably safest and longest as much as possible. One important thing, very important thing is if the patient has insight to his or her abilities. And that's part of also cognitive function, retaining insight. As long as a patient has insight, I trust them more in terms of safety, even if they are slow and stiff and etc. So I think insight is very important. But again, objective testing by experts is important too, because sometimes insight can be lost and people can be getting used to their own slowness and deficits. So, as Derrick said, we are here for you. Obviously you don't want to be on the road yourself, hurting yourself, hurting others on the road either. So we just work together as a team.
And I think that's the most important thing to think about too. It's not just your safety, but it's the safety of others. And I always like to kind of put that into perspective that, if you are having troubles, and give people their due diligence and praise them if they do make that decision to retire from driving, because it is a difficult one. But recognizing that, you know, if it was your grandchild out there on the road and there was somebody exhibiting these difficulties in reaction time, would you want that person to be out there on the road too?
Well, thank you, everyone. I'm going to thank you again for your participation and for our viewers today. I just have a few outgoing messages to share. So thank you so much, Dr. Uc, Hillary, Derrick, Gino, and Kathy for sharing your time and expertise with the veterans community. And thank you for all our attendees joining. We hope you find today's discussions helpful as you navigate your Parkinson's journey. Immediately following today's program, a survey will pop up so you can fill that out and share your feedback with us. We love to hear how we can improve our programs for the future to better serve you. And it is so important to us. Today's program was recorded and a link to the video will be emailed out to all event registrants in the next week. Presenter slides and other resources will be included. And please know you are not alone. Our respective organizations are here for you and we look forward to connecting with you. If you have a question that was not addressed today during the Q&A, please reach out to the Parkinson's Foundation helpline Monday through Friday with Parkinson's related questions at 1-800-463-47. Now I'm getting screwed up. 1-800-473-4636 or email helpline@parkinson.org or contact your local VA medical center. Thank you again for your service to the country. We hope you enjoy the rest of your day.